Hello, this is a recording on Patient Care Chapter 14, which begins on page 153 of your Patient Care textbook. And this is all about immobilization techniques that we use in our field to assist with patients. When we look at immobilization principles, they reference that motion distortion is one of the most significant contributing factors to unacceptable image quality, meaning if the patient moves, that would be cause for us to repeat an image, which means re-radiating the patient. Positioning inaccuracies can also contribute to suboptimal image quality, meaning if you're not positioned properly or the patient's not maintaining the position you put them in, that can also lead to repeats. Motion can come from involuntary motion or voluntary motion. There are actually three types of motion. There is voluntary motion, involuntary motion, and equipment motion. So voluntary motion is motion that is under the control of the patient, like not moving, holding their breath, things like that. Involuntary motion is things they can't control, like their heartbeat, peristalsis in their abdomen, things like that. And equipment motion is when the equipment actually moves, and that's not really the fault of the patient. Typically, that is completely tech error. When they talk about patient restraints, they can be either simple or complex, and we'll discuss some of those. Communicating with the patient is probably the most critical thing you can do to utilize effective immobilization, meaning if you communicate with the patient and let them know what it is you need them to do, why you need them to do that you're trying to get an optimal image so that the radiologist can diagnose what's going on with them, most patients want to cooperate with you. You always want to use the shortest exposure time possible to minimize the chance of distortion or motion, meaning if you can achieve the image using less time factor, then that helps the patient reduce the chance of them actually moving for the exam. We are always encouraged to use immobilization aids if possible. Having empathy with the patient's condition can be an effective thing to do when you're facilitating good immobilization, meaning acknowledging that they're in pain, understanding that it's not comfortable, telling them that you recognize this is not the most desirable thing that they choose to do, but that you are going to work quickly and efficiently while keeping them safe and getting an optimal image. When they sense that you are empathetic to their situation and that you're trying to do the best you can for them, then a lot of times that will help them improve their cooperation level. Be aware that some immobilization devices can leave artifacts on the images, meaning that some of the devices we use are not radiolucent. When an item is radiolucent, excuse me, when an item is radiolucent, it means that X-rays can pass through relatively easily, almost like translucent when light passes through. So radiolucent means that X-rays can pass through. So things like air are radiolucent. Something that is the opposite would be radiopaque, meaning that X-rays don't pass through relatively easily. So something like lead, the lead shields that we use, a sandbag that we use to help immobilize a patient, those items are radiopaque. So when items are radiopaque that we use, sometimes you can leave an artifact on the image, meaning that the radiologist will be able to tell that you used something. So you always want to indicate if you used an immobilization device so that if he or she sees something on there, they could deduce whether or not that was what it was from. Okay? When we use immobilization devices, there are different ones. We have positioning sponges that we can use, sheets, sandbags, Velcro straps, head clamps, and there are some commercially made devices. But most of the time, it talks about that if you improvise and use your own creative capabilities, that is often very effective when you're trying to come up with an immobilization device. You can use things like tissue boxes, glove boxes, anything you have in the room. If you can creatively think it and problem solve with it, then by all means it becomes an immobilization device. The positioning sponges and sheets and sandbags, Velcro straps, head clamps, those are things that we tend to have in the department. And if you look on page 155, they beginning there is when they start to show you some of those devices. Some other things we have are cervical collars, spine boards, splints, sheet restraints, commercial restraint devices that we'll look at, especially with pediatric patients, stockinettes. Tape is probably your best friend. You can learn to use tape very creatively. You just have to be mindful of how sticky it is and the fact that it can rip patients' skin. So you want to try and use the non-sticky side against the area that's injured if possible, or put something between the sticky and the skin like gauze if you're going to use it. And also Velcro straps can be used. As far as our positioning sponges, we used to use these quite often. The positioning sponges were very helpful. They helped patients maintain positions. They were able to support the patient in the correct anatomical position, aid them in not moving. The downside with this, if you can see the sponge, is that you cannot clean this sponge. This is porous material, so a lot of these are no longer in use, and you won't find them in the department because anything, blood, body fluids that is on that patient is going to be transferred to that sponge, and there's no way to clean it. They do make sponges that have coverings that are able to be cleaned. We do have some of these in the lab. If you check those out, they're green. I will tell you that that covering that is able to be cleaned does leave artifact on the image, but that would be a potential that you could use. But most of the facilities that we use for clinical sites tend to have thrown all their sponges out and not ordered more. So sandbags, like those sponges, if I go back for a second, these also are very radiolucent, very lightweight material. These very lightweight. The ones that I'm telling you that we have in the department that are green, they're a little bit thicker, so they're a little more radiopaque than this would have been. Okay, this may no artifact on the images whatsoever. But when you get to things that are a little more radiopaque, like the sandbags, sandbags literally are full of sand, and sand is very radiopaque, but they are useful as an immobilization device. I'll be honest with you, I have never laid a sandbag on a patient's hand for an elbow or on their elbow for a hand. It's just not ideal. These usually weigh 8 to 10 pounds, and if you've ever laid with your arm extended and put that on the palm of your hand, it really is painful on the elbow. So I've never used them in the way they're showing them. But what we do use them for, I think they show a little bit later, but if not, if you look on page 157, figure 14.8, where she's standing in a erect lateral position and she has the sandbags in her arms, that I have used them for, to pull the weight of the shoulder down, but I've never used them in this capacity. Tape, hands down, your best friend. You can use it in so many different ways. You can see that they have this child with her lower extremity on the IR, and they've got a piece of gauze between the sticky side and the patient's skin. This one here, you can see a twist in the tape. So what they've done is stick the sticky side to the table, bring it up, twist it so the non-sticky side is on the patient's head, and then twist it again so that you stick it back to the table. And most of these immobilization devices are not designed to keep them in place no matter what. What they are designed to do is to remind the patient to hold still. That's all they're trying to accomplish with that. On that same page 162, you will see in 14.19 the stockinette. Now this is a stretchable fabric that is shaped like a sleeve that goes over typically a fractured extremity before they apply a plaster cast. So sometimes we have these in the departments. They work as a restraint. If you pull it over the upper or lower extremities of a child and secure it with tape. This would just be designed to keep her arms above her head so that she couldn't bring them down and get them in the way of the picture. Okay, again, not designed to prevent her from moving, just to remind her when she goes to move, oh, my arms are in this, I'm not supposed to move for this exam. A stability bar. This is not in the book, but this is absolutely something that you will see out on site. These are devices that are helpful to not only elderly patients, but all patients. When the patient is standing sideways at the board, they can put their arms, they can rest their arms over this bar, not to hold themselves up, not to do pull-ups on, but just as something to stabilize them so that they're not wobbling back and forth by trying to stand still at this board. So these bars, most of our facilities have something like this where patients can hold on to that and keep them from moving, especially for lateral chest x-rays. We have spinal trauma immobilization devices. Now, most of the time, these are not things that we are putting on as far as the spinal trauma. This is something that the patient usually arrives to us with this in place. So this is on page 158. The most common spinal trauma traction device is the cervical collar, which you can see the patient wearing here. And the cervical collar is typically on a patient when they suspect cervical injury. Most motor vehicle accidents, you will find patients come in with these on through the ambulance. But what it's doing is to immobilize the cervical spine to prevent motion so that you reduce the potential of a traumatic injury to the spine and risk paralysis. So a lot of times they're placed in these cervical collars. They'll come in also on a backboard. This is this spinal backboard right here. So when they have a motor vehicle accident, they'll come in with both of those. And typically what we do is to take 3 images of the spine. We take a cervical spine, a lateral first, and we typically get that cleared with the physician to make sure that they're able to remove the cervical collar, or to confirm that there is an injury and we need to do the rest of the images with the cervical collar, in place. So we do what's called a cross table lateral, meaning you can see here the image receptors on the other side of the patient. The x-ray tube would be over here, and it would have a horizontal beam going through the patient taking a picture of her cervical spine. That would then be cleared by a doctor or an attending physician. And then once they clear it or confirm that it needs to remain in place, they would tell us which was the case. Okay, and you would leave them on the backboard as well while you were doing this. This backboard or spine board is designed to immobilize not only the entire spine, the thoracic, lumbar, but also assists in immobilizing the pelvis and the lower extremities as well. Notice it says cervical collar should not be removed until a qualified practitioner assesses the images and determines it's safe to move the patient. And that qualified practitioner is either the radiologist, the attending physician, or a neurosurgeon. We are never allowed to clear films for cervical collar removal. When we talk about spine trauma, a spine backboard is very common. You will see patients come in on these backboards. And typically the nice thing about this and the cervical collar is that these are radiolucent. This is typically made of a foam material with a little bit of hard plastic right here in the front that goes under the chin, and another piece of hard plastic back here behind the neck, and then the foam in between, and this velcros around. Typically the backboard is radiolucent material as well, so not only does it help immobilize the patient, but it won't show on our images, even though you would still note images were taken with the patient on a backboard and a cervical collar. Pediatric immobilization devices. Again, you cannot stress the importance of communicating with pediatric patients and developing what's called rapport. Rapport is your rapport that you develop with a patient, and you develop like a relationship, or um, you develop harmony and accord between two people. And typically, rapport starts the minute you lay eyes on the patient or the patient lays eyes on you. If you tend to have like an outgoing personality, you're always smiling, you're warm and friendly and inviting, then typically rapport is not something that is hard to establish with a patient, because as soon as they see you, you're usually greeting them again with a smile, positive body language, and you're coming across that you're caring and kind and compassionate. With pediatric patients, they pick up on as well, probably more so than adults. Okay. They reference that kindness, patience, honesty, and understanding conveyed to a child on their level goes a long, long way. There's a thing on page 159 where it says a chief radiologist at a hospital in St. Louis was quoted as saying, to stand tall in pediatric radiology, you have to get down on your knees, meaning that if you think about child's perspective, their eye level, a lot of times their eye level is, you know, your thigh, your femur, your backside, the front. Their eye level is not at your eye level. So when you get down to their level, either you bend down on your, you know, on a knee, or you place them on the table and raise the table up, or maybe you sit at a level lower than them so that you are at their eye level, that tends to go a long way, because when they're looking at you and you made an effort to come down to their level, they perceive that as kindness and genuineness. Even if it's a young child, if you bend down and talk to them, usually their face will light up because you've come down to their level. As far as peds, and I would argue with all patients, you never want to threaten a patient or force a patient to do something. The use of restraints is designed to help them. They should be applied gently. They should be applied after the patient or whoever is responsible for the patient consents to them being applied. Especially with pediatric patients, you want to work with the parents. They're often more difficult to manage than the child. And you always want to follow department policies and procedures with regard to using immobilization devices. Now, on page 160, they talk about this sheet restraint for infants, which they call mummy wrapping, okay, or a mummification technique. Now, make no mistake, this is not a simple device. When we've talked about the things so far, like sponges, sponges are fairly simple. Sandbags are fairly simple. The stability bar is simple. It has a purpose. It's typically one step and you're done. When you mummy wrap a child, this is a more involved, more complex procedure. If you look on page 160, there are specific ways you have to lay the triangle sheet a certain way, lay the baby in the triangle. Then there's a certain corner that has to be brought over the patient's arm and underneath their back, and then you have to follow this with the same thing going over and under, and then you bring this one over and you swaddle them. I mean, I've never mummy wrapped a patient. I can tell you I've swaddled my children, but this is definitely not a simple thing to do. And honestly, I know they do this kind of stuff in the lab when they have to start an IV. They'll use like restraint boards or they'll mummy wrap a child, but it is not something I would tell you that we see a lot in our department. But it is, it's an easy way to restrain a child, but this is not a simple device. This is very specific steps. So this is definitely more involved than using a sponge or a stability bar. There are some commercial restraints on page 161. You can see that PediaPoser, that and the Pigastat, which is right next to it, are considered upright restraint devices. The PediaPoser and the Pigastat are typically done for chest x-rays. We'll go there real quick. This child is placed in the Pigostat. There's like a little bicycle seat under here. Her legs are dangling down. If you could see her, she's seated with her legs down. These are plastic, like little plexiglass things that come around her body with her arms up. And then there's little leather straps that hold these in place. This does not hurt the child, but it looks barbaric. Okay, the child cries. Why do they cry? Because they don't like to be restrained. Children do not like to be held still, so typically they cry. In this scenario, I know that sounds mean, but it's a good thing because you're trying to get a picture of her chest. And if she's crying, it means that she's breathing deeply. And when they breathe deeply, they inhale more air, their lungs inflate bigger, and you get a better image. So crying when you put a patient in a Pedioposer or a Pigostat is a good thing. The sadder part is when you put them in that and they don't cry because they're so sick they don't really care what you're doing. That's when it's heartbreaking because you know that baby is very, very sick. But if they cry, that's actually good for us. Parents don't typically like to hear them cry, but we tell them it's good. It'll give them a deeper inspiration, so that's okay. We're going to let them cry. Those are the upper devices. They also mention back here that there are restraint boards that are contour fitting pads or molds or sponges that have Velcro straps to secure the patient. And one of those is called an Octostop restraint board. So the patient can be rotated. These are like stop signs on the end. So there are 8 different positions that the patient can be rotated in, from flat on her back all the way on her stomach, and then equally obliqued up in certain positions with that Octostop board. So they can rotate 360 degrees into 8 different positions. It is radiolucent plexiglass. It is very durable, but you only use that when the patient is up to 1 year old. Pediatrics are not our only patients we're concerned with immobilizing. We are also concerned with geriatric patients. And the geriatric patients, it can be challenging. Pediatric patients are challenging because a lot of times you have to change up how you communicate with them. They might not understand your words or your terminology. They might not even be able to communicate at that point. They might not have their language yet. But geriatric patients pose a challenge as well, because they also may or may not have good communication skills. They might have diminished mental capacity. It just depends. But I can tell you with geriatric patients, their greatest fear is falling. They are terrified. They like to move slowly. They don't like sudden movements. They like you to explain what you're going to do to them. Don't make them move fast. Don't want to catch them off guard. You don't want to have them lose their balance. So their greatest fear is falling. Communication is critical with geriatric patients, and you want to do whatever you can to make them feel secure. Okay, you want to make them comfortable. If you can have the radiolucent pad on the table, that is ideal. Extra pillows might be necessary, blankets to keep them warm. So fear of falling is their #1 fear. Behind that would be that patients are typically cold. Geriatric patients are cold. All patients, I would argue, are cold. A lot of times the hospitals are kept at probably 68 to 70 degrees to keep germ spread down, to keep the multiplication of germs down. And we don't really feel it because we're running around all the time. But patients that are lying still, lying in their beds, they absolutely feel that. So warm blankets are a blessing for them. Extra layers of sheets can be helpful. Just be mindful that the patient could be cold. The third thing is their comfort level. Absolutely is their comfort. That would be a third thing. So again, extra blankets, pillows, a radiolucent table pad. Keep them warm. You want to work smoothly and avoid working quickly because you don't want to disorient the patient, and reassure the patient by paying attention to their comfort level. Ask them, are you doing okay? I'm so sorry. I know this isn't comfortable, but I'm working as fast as I can. And as soon as we get this image, I will get you in a more comfortable position. Just acknowledging the fact that they're uncomfortable a lot of times will help them help you and cooperate better. Okay, so all different kinds of immobilization techniques. The biggest thing would be to communicate with your patient, let them know what you're attempting to do, and always try to be mindful of how they're feeling or what they're thinking and acknowledge that. In conclusion with this, motion is a key factor in final image quality. You do not want images with motion. The radiologist does not want images with motion, if at all possible. You should not pass images that have motion. If there's motion in the intestines from peristalsis, that is not something you can control. So that would be acceptable on some circumstances. Always try to use very short exposure times to lessen the chance of motion distortion, and communication is your best choice. Short exposure time always, but communicate with your patient. Tell them what you're trying to accomplish, why you're trying to accomplish it. It's for them, for their image, for the radiologist. But if you communicate that effectively, they usually will do their very best to work with you. It's when you don't explain things and you start yanking them around and jerking them into position that patients get, typically they get mad, they get annoyed, they get aggravated, they're not comfortable, and then they'll start to fight you, and that makes it 10 times more challenging. So always try to communicate with your patient and let them know what's going on. Pediatric immobilization requires being creative and adaptable. Deal with the parents according to the department policy. A lot of times, again, if you explain to the patient that you're just trying to get the best possible image for the radiologist for their child, they'll understand that. Use an immobilization device if it's appropriate. Like I said, the Pigastat, things like that, a lot of techs will shy away from that because they feel like it looks like it's harming the patient. But honestly, I'd rather you put my child in a Pigastat and have them cry and get a decent image on them the first time than not use it because you're trying to be nice. Have to take 3 chest x-rays and you've just radiated my child 3 times. Now, I know better because I am a technologist. Some lay people do not know better, but just think, for the safety and radiation protection of your patient, whether they're pediatric, geriatric, or somewhere in between, you always want to adhere to that ALARA principle, even if it means having a baby cry for 20, 30 seconds. That's okay. In the long run, radiation dose to that patient. And last, beware of image artifacts from immobilization devices. Again, those things that are radiopaque will show. Just let the radiologist know. Put it on the requisition. Say that you use the Pigastat, or say that you use the positioning sponge, or a Velcro strap, or a cervical collar was applied, or not applied, was on the patient when you received the patient from the emergency room. Just something so that when they dictate, they can note that, and it doesn't look like there's something else on the image that could be wrong with the patient versus an immobilization device. All right, and that wraps chapter 14. If you have any questions or comments or concerns, please make sure to note it on the slide where you were questioning it. And when we meet again, we will discuss and try to answer those questions. Thank you so much.